case of primary fertility problems is for somebody who's never been pregnant and it struggles to get pregnant, and as I mentioned earlier on during this episode, they may be trying for 12 consecutive months with no luck. Secondary is somebody that has conceived, has had a healthy baby, and then comes back for a second cycle, for a second pregnancy, after trying for 12 months. There could be problems that have developed from that pregnancy, and there could be problems that have been acquired since that pregnancy. And examples are women that have conceived spontaneously with no problems, and they've gone into labor and they've given birth by cesarean section. The cesarean section could cause some damage to the uterus, and they could actually find difficult to conceive again.
We are back. It's a brand new episode of Tell Me Why. I'm Maria, as many of you already know. Today's topic is an interesting one, and it is one that I feel that we don't talk enough about. And I feel like there's so much to address with this specific topic. I feel like it will resonate with a lot of people. And that topic is infertility, or let's say fertility. So infertility and fertility. And joining me in the studio is Professor Luciano Nardo, who is the founder of NOW-fertility as well. And today we really want to dig deep into this topic because I feel like it affects a lot of people. The WHO published an article or a report in April this year saying 1 in 6 people actually face or suffer from infertility or face fertility challenges, let's put it that way. And I think that's a shocking statistic, and that is something that we would love to address with you here today, being the professor and, the professional in the field. First of all, Luciano, how are you?
I'm very good, thank you, Maria. It's been a pleasure being here today. Thanks for the invite, and thanks for offering me the opportunity to talk to your audience.
Thank you so much. Before we begin, we want to get to know you first. Tell us about yourself. Tell us about how long have you lived in the UAE so far? Where have you been around the world? That kind of thing.
Sure. So I'm originally Italian. My family has got a mixed background. Some from North Africa, some from Sicily. I was born in Sicily, grew up in Italy, moving to Switzerland and spending 25 years of professional life in the United Kingdom before moving to UAE, where I'm fully based now. And I am in the process of starting a new fertility and IVF clinic within a state-of-the-art compound.
Amazing. You mentioned North Africa. I'm North African myself, so I hold that proudly. You said that you are in the process of, opening up and growing your fertility center. What made you open that? What gave you that drive or that push?
Yeah. At NOW-fertility, we have an international group of physicians, nurses, and patients coordinators. We know that fertility is a growing problem, but also we know that through fertility treatment we can address non-fertility issues, such as having healthy babies, preserving fertility for cancer patients. So in 2023, soon 2024, fertility treatment opens many more doors to prospective patients and members of the public compared to 25 years ago when I started.
Yes.
So UAE and the Middle East is a growing market because more and more people are becoming aware of fertility problems. And also there is a large population of expats that are looking for fertility solutions. And they want to rely on an international profile Hence
Right.
why we're bringing doctors, nurses to work in UAE and be part of the UAE fertility market.
Right, right. You mentioned two things. So you mentioned something along the lines of that infertility is on the rise and that more and more people are facing it. And one of the things you mentioned was preserving fertility, or I would say eggs or whatnot, for people to get pregnant in the future, especially with cancer patients. And that's actually one of the questions that we have from a listener that we will ask in the end. But going back to the fact that it's on the rise, I actually want to ask that question. Why is it on the rise? What are certain causes that could be causing this?
The causes in 2023 are very different than the causes in 2020 and 2015.
Okay.
What we are seeing, there is more awareness. So more couples and individuals look for investigation that show actually there is a problem.
Right.
We also know that women, because of career progression and because of not finding the right partner, may leave it too late.
Right.
And we know also that in some countries, not the Middle East admittedly, but there are some health issues that affect fertility, such as infections that can cause blockage of the tubes,
right,
smoking and drinking that can affect both female and male fertility.
Right.
So there are multiple reasons why fertility is rising. Some are related to underlying medical problems, whereas others are, we call them lifestyle choices or social reasons.
Okay, so this topic is just so interesting, and there's so many layers to this topic, and so many questions come to mind. So I'll try to keep it organized so that we can keep the conversation flowing. But when you mentioned infertility, first I want to define what infertility is, because I feel like a lot of people might have misconceptions. I mean, it's not so much as, oh, we've tried for 2 months, I'm infertile. It doesn't work that way, and we need to really shed light on the fact that infertility is not just on the woman. I feel like that misconception still exists. A lot of people think that it is only from the female side. However, it affects both genders. So I would like you to explain that further.
Absolutely. So the definition of infertility is different compared to the definition of subfertility.
Okay.
So we often say a couple is infertile or is suffering with infertility, but most of the couples have subfertility, which means the fertility is not optimal.
Okay.
When we name a couple as infertile, we say actually they have no chance of getting pregnant.
Okay, and that exists.
And that exists. And example of that is a woman that has lost her ovaries.
Right.
An example of that is a woman that has got no fallopian tubes because of previous ectopic pregnancies. Or it could be a man that has got no sperm, whether that is for an acquired condition or a genetic condition. So there are obviously some couples and some individuals that are infertile, but admittedly they are just a small proportion of the patient population.
Right.
Most are instead subfertile.
That's a new term for me. See, I never knew that.
And I personally don't like to label somebody as infertile or subfertile,
right?
Because it's not positive. And when you embark on this journey, you need to embark with a degree of positiveness.
Right. Right.
So I always address as having fertility problems. So they want to overcome the fertility problem. They don't want to overcome something that could be infertility or subfertility. But clinically speaking, we define as infertile somebody that is unable to conceive. So a man that has had a vasectomy, for instance, is infertile.
Of course, yes.
But a man that has got low sperm count is subfertile.
Okay.
How do we reach the conclusion clinically about defining or labeling somebody as being subfertile going back to the fact, I'd rather say I've got fertility problems, is by undertaking some investigations.
Okay.
And worldwide, we and a couple would start undergoing investigations after trying to conceive for 12 consecutive months.
Okay.
So if a normal couple, otherwise healthy, with no underlying medical problems and not genetic problems that would represent otherwise an underlying fertility issue, I've been trying to conceive for 12 months, having unprotected regular sexual intercourse, and they haven't conceived after 12 months, then they may be subfertile. And the definition of subfertility comes from the fact that probably around 75% of couples trying to get pregnant within 12 months would conceive.
Okay.
So the fact that the majority would achieve a pregnancy within 12 months means that the minority will have a fertility problem.
Okay.
And that fertility problem has to be investigated. So the 25%, 20% that will not achieve a pregnancy spontaneously within the first 12 months of trying undergo some investigations.
Okay.
And it is important at this stage to say that both the man and the woman have to be investigated. If I'm only going to investigate the female partner, I can only identify potential problems with the female partner. Equally, if I'm only going to investigate the male partner, I can only identify male factors affecting fertility. But in about 1 in 4, we have a combination of male and female factors. So investigations are deemed appropriate after 12 months of trying.
Okay.
And both partners will need to be investigated.
Okay. So mentioning investigations, can you tell us examples of what these investigations entail and what actually happens for you to come to the conclusion or the diagnosis?
So the first, before we talk about investigation, Maria, I think the most important part of the clinical day-to-day work is to understanding the patient. What are the lifestyle factors? What are the underlying medical problems? Chronological age.
Right.
These are just basic information we obtain from the patient, from the couple. Once we have completed the first step, which is acquiring information, then the investigations will be for the female partner a blood test to assess ovarian function, and the blood test measures a hormone called AMH.
Okay.
AMH stands for anti-Mullerian hormone. It's a very reliable marker of ovarian function. It's a blood test, can be done anytime during the menstrual cycle. Can even be done if a woman is taking the contraceptive pill. It doesn't really affect the AMH levels.
Okay.
So an AMH test can be done anytime in the cycle. Then we would recommend to have a pelvic ultrasound scan. Ideally, if the female partner is sexually active, which we expect to be sexually active, she's been trying to conceive for 12 months, a transvaginal ultrasound scan is more accurate than a transabdominal ultrasound scan.
Okay. And
the transvaginal ultrasound scan should be done between day 2 and day 5 of the cycle, of the menstrual cycle.
Okay.
The reason why it's important to do within the first part of the menstrual cycle, because at that stage, looking at the ovaries, we can see the follicles that are little small cysts present within the ovaries. And according to the number of follicles, you can prognosticate ovarian function. Okay. If I was to do an ultrasound scan later on in the cycle, I may not be able to see the normal morphology and function of the ovary. So an ultrasound scan, ideally transvaginal scan, is done within the first 5 days of the menstrual cycle.
Okay.
And ultrasound scan will look at the ovaries, and will also look at the uterus, at the womb, to make sure there are no other possible factors affecting fertility. The third test that I would encourage women to do is a test to check the fallopian tubes. Right. To make sure that the tubes are patent, are open, because blockage in the tube could be a cause of infertility.
Right.
For the man, we would recommend to do semen analysis to check the sperm parameters. And if there is any abnormal sperm parameter, or if there is any history of testicular trauma or surgery or any testicular symptoms, we would also recommend an ultrasound scan of the testicles to exclude any factors that could impact on normal spermatogenesis.
Okay. All right. So my next question, now that we spoke about the investigations and the kind of tests that women and men undergo to reach the conclusion that they have challenges with fertility, as we like to put it, rather than infertility, what's the next step? Excuse my ignorance, because I think the only treatment I've ever heard of was IVF. I don't know if there are other treatments. I don't know how successful they are. Maybe if you could explain to us, like to me and the listeners, what are the types of treatments? Which one do you resort to in which cases? Because I'm assuming certain cases need special attention and others will require certain treatments. So if you could just talk to us about that.
Yeah. I think doing the investigations is very important, because from investigations you can first find out if there is a problem.
Right.
If you do not find a problem, then you need to speak to the couple and make them aware that maybe that the treatment you're going to propose is not going to be effective because you haven't nailed down the problem.
Right.
So investigations are very important. Based on the investigations, you can then propose different management options. Again, it's important that we explain the difference between management and treatment. A treatment normally guarantees an outcome. But with fertility, there's not always the guarantee of an outcome.
Right.
And also, with fertility problems, you may need to trial different options before actually you achieve that outcome.
Right.
So calling IVF, for instance, a treatment may raise expectations rather than calling IVF a management option of fertility treatment. So once we do the investigations, we then find out what is the problem, if there is a problem. And the problems could be associated with the male partner or the female partner.
Right.
The problems in the male partner most of the times are amenable by IVF. So men that have low sperm count, men that have abnormal appearance of the sperm, men that have low sperm motility, they're a good candidate to IVF. And in my 25 years experience, they're the ones that have the highest success rate.
Right.
Because IVF will overcome the problem associated with the male partner, with the male factor.
Okay.
The female, there are different reasons or different causes of subfertility. Could be to do with ovulation.
Right.
And if women have a problem with ovulation, they do not need to have IVF. They may just need to take some medications to turn around the ovulation problem and actually ovulate.
Oh, okay. Okay.
There could be problems with the thyroid function, where the thyroid may produce some antibodies or may affect the ability of that woman to conceive naturally.
Right.
It is important that that thyroid issue is resolved before any fertility treatment.
Right.
Because if the woman undergoes fertility treatment, she still has an underlying thyroid problem, will still be an unsuccessful outcome.
Outcome, exactly. Yes.
There could be problems associated with the normal anatomy of the pelvic organs. So, for instance, women could have a polyp, which is a benign lump within the uterus. Again, that is a factor that will affect fertility, but naturally and by means of IVF.
Okay.
So there is no point to recommend fertility management in the form of IVF to somebody that has got a polyp, because that will still be a barrier to a successful outcome.
Right. So treating the problem in order to get, because some problems might hinder the progress that you do,
Correct.
that you get,
Correct.
with a
Correct.
treatment. Yes.
Correct. And to be very specific, the main indications to IVF are male factors, so abnormalities in the sperm parameters.
Okay.
Blocked fallopian tubes. And in other cases is the need to do IVF with a view to testing the embryos.
Okay.
Should there have been repeated miscarriages or repeated unsuccessful attempts to conceive.
Okay.
Sometimes IVF is recommended too soon without undertaking the correct investigations.
Okay.
And in that case, couples may undergo 2, 3, 4 cycles of IVF to no avail, finding out that the problem is not actually one that can be overcome by IVF. So I'd like to reiterate to the audience that it is very important to have investigations, and it is very important to wait for the results of the investigations before choosing the best management option, which, in my experience, only in about probably 35% of cases is IVF.
Wow.
In other cases, you may need hormone treatment to resolve the anovulatory cycle into ovulatory cycle. You may need surgery to remove a polyp or a fibroid.
Right.
You may need to have a treatment of the thyroid. You may simply have to wait a bit longer. But one thing that we are facing daily in clinical practice now is IVF for advanced maternal age. So women that are chronologically older than 35, they're aware of the impact that their age could have on future fertility.
Right.
So they use or they request IVF to shorten the time to pregnancy. Admittedly, the chances of conception, natural conception, in anyone healthy having a regular unprotected sexual intercourse is about 20-25% per month. So it is not very high if you have expectations.
Right, yes.
The chances of success with IVF could be twice that, 50, 55, 60%. So in some cases, IVF is done as a way to shorten the time to pregnancy.
Okay.
But for that, I was saying earlier on, it's not actually a treatment, because a treatment means you have got an underlying problem. You have got a condition, and you're treating that condition, but sometimes it's not.
Right.
And I don't think we can say that chronological age is a condition.
Of course.
for and therefore an indication for IVF or any fertility management option.
Yes.
But that's what we're seeing today, where more and more women in a stable relationship, married, they are thinking to have a family later on in life, and they may just come for IVF after 2 or 3 months of trying.
To speed up the process, as you said, and
Correct.
to shorten that period. Okay, my next question is about, because I've seen this with some cases, with some friends and people in my close circle who were, had an easy first pregnancy, but their second pregnancy was not as easy, or vice versa. Is it possible for someone to be fertile and then infertile, or face fertility problems for the second pregnancy and vice versa?
It is absolutely possible. In fact, we call primary subfertility or infertility, and secondary infertility or subfertility. And I'll give you different examples. A case of primary fertility problems is for somebody who's never been pregnant and it struggles to get pregnant. And as I mentioned earlier on during this episode, they may be trying for 12 consecutive months with no luck. Secondary is somebody that has conceived, has had a healthy baby, and then comes back for a second cycle, for a second pregnancy, after trying for 12 months. There could be problems that have developed from that pregnancy, and there could be problems that have been acquired since that pregnancy. And examples are women that have conceived spontaneously with no problems, and they've gone into labor and they've given birth by cesarean section. The cesarean section could cause some damage to the uterus, and they could actually find difficult to conceive again because of some scarring or defects that occur at the site of the cesarean section. So there is a condition which is called cesarean section scar defect, which affects the chance of conception. Other women may have conceived the first time, no problem, and since then developed thyroid problems. May have developed some blood clotting problems where the blood becomes sticky, and that could impact on fertility. The fact that they have conceived once does not guarantee that they can conceive any times they want thereafter. And also, Maria, what we need to bear in mind is that depends on when the next pregnancy is going to happen, because somebody may have tried to conceive at the age of 34 and actually is now started to conceive at the age of 38. So age is an important determining factor when it comes to fertility. So I always say to patients and to my colleagues and to the public, just don't bank on the fact that you conceived once. Because there is no guarantee.
And to be honest, there was my uncle is a gynecologist. He's actually the head of gynecology in a hospital here in the UAE, and he was saying every pregnancy is different. Every pregnancy. We're not talking from woman to woman. We're talking from the same woman. One pregnancy can be one way and the second one can be completely different. There are so many ambiguities and so many, there are different factors in each pregnancy. It's never this is how it's supposed to be or this is how it's going to go. It's very unique. Every pregnancy is unique. Every pregnancy has its challenges. Every pregnancy has its journey, and you can't generalize when it comes to pregnancy. So I absolutely agree with you. Okay, I know that time is tight and that your time is gold, so we are going to ask 2 questions from listeners. The first one, Liana messaged in saying, I'm 32 years old and we have been trying for over a year now to conceive. I still don't want to go to a doctor because I don't think it's necessary, but if I do end up going, can the doctor identify the cause of the infertility if I end up getting diagnosed, and how do they identify it?
As we mentioned earlier, there is no guarantee that there is a condition. There's no guarantee that there is a cause of
or like a specific cause,
and also depends on the investigations.
Right.
So the preliminary investigations I mentioned at the beginning of this episode, such as the AMH test, the ultrasound scan, the tubal patency test, and the semen analysis, and potentially an ultrasound scan for the male partner, they're not going to cover all the problems. There could be some genetic conditions, and the female and male partner need to be investigated by having a blood test for a chromosome analysis. So I think the easy reply to your listener is probably in about 60 to 65% of cases, we do identify a problem.
Okay.
We do find a cause.
Mm-hmm.
But that cause may not be found the first time you go to your specialist.
Right.
Because the preliminary investigations are not going to be covering every single
Mm-hmm.
Possible problem.
Right.
And the reason why is because by doing all the investigations at the outset means the costs will be very high.
Of course.
When we know the majority, which means more than 65% of the population will have no problems.
Right. Right. No, absolutely. I hope that helps, Liana. It's a good question, and I feel like a lot of people don't want to admit that there's something wrong, or if they do end up, addressing the issue, they want a specific cause. They just want to hold on to that, but sometimes that's not the case. Okay, this person preferred to be anonymous, but we're going to ask it because it's actually an interesting one. It's one I thought of. I don't have an issue, but I found it fascinating that so many twins were born after infertility treatment. Why is that? It's an interesting one.
It is an interesting question, and I would like to again say before talking about why that there is a worldwide attempt and perhaps adopted practice to reduce the risk of twins.
Okay.
So many regulatory bodies and many authorities are insisting and imposing some sort of guidance to clinics to ensure that only one embryo is transferred at any one time.
Mm-hmm.
This leads to, I think, to speculate, to answer that actually the reason why there are so many twins, or there were so many twins perhaps, is because multiple embryos were transferred at the same time.
Oh, okay.
So if you look at the instance of somebody conceiving naturally, you will have one egg being fertilized by one sperm and one embryo that implants inside the uterus. It is possible that embryo splits and you have identical twins.
Yes.
But when it comes to IVF, if you transfer multiple embryos, they are not identical twins.
Mm-hmm.
And they are caused by having more than one embryo implanting at the same time. So by reducing the practice of transferring multiple embryos, we are reducing also the risk of twins.
Okay.
And twins are not ideal because the space within the uterus is limited. Twins have got some risks in pregnancy for the babies, but also they have got risks for the mother.
For the mother, of course.
We know that women that carry twins have increased risk of gestational diabetes, of mid and second trimester of pregnancy problems, increased risk of high blood pressure, increased risk of having a cesarean section, and for the babies, I think the main risk is that if they come premature, which is very likely, then they can come out with some neurological problems, and the commonest one being cerebral palsy.
Yes.
So you want to ensure that you minimize the risks of twins in order to optimize the live birth rate.
Okay. So the short answer to this anonymous person's question is that more than one embryo was transferred, at least in the past, before this warning has been issued.
Yes.
All right, fantastic. Luciano, it's been a pleasure. Thank you so much for joining us. We'd love to have you back. I feel like this topic is going to get a lot of responses. If any of our listeners want to send in their questions, please feel free. We are on social media on the Gulf News Instagram account, and you can always email us on podcast@gulfnews.com. Get in your questions. We'd love to have Luciano back, answer them, and we can have like a Q&A session, which we discussed actually before the show. Thank you so much for your time.
Thank you, Maria. Thank you very much.